Hi, good afternoon, and thank you for joining our webinar today, Protecting Confidentiality Part II, Case Studies and Best Practices. If you are viewing with a group, please go to your chat box and enter the name of the person registered plus the total number of additional people in the room. For example, Tammy Jones plus 3. This will help us with our final attendance count. We have a few housekeeping reminders before we continue. This presentation may be downloaded now. You can access the PDF of the PowerPoint slides by visiting www.sbhforall.org/webinars. All attendees are in listen-only mode, but we do want to hear your questions throughout the webinar. To ask a question, please go to your chat box in the GoToWebinar control window pane. We will be presenting multiple case studies and we'll have time for several questions after each individual case study. And as you all know, confidentiality laws differ widely based on the location that you're providing services in. So we'll do our best to answer as many questions as we can on this webinar. However, if we don't get to your question on the webinar, we'll be in contact with you via email after the webinar. You will receive an evaluation survey after this webinar. Please let us know how we're doing and any topics you'd like us to cover. We do archive all of our webinars. You can access a complete list of our archived webinars by visiting our website at www.sbhforall.org/webinars. By the end of this webinar, we expect you will be able to describe the legal framework and identify confidentiality challenges related to sports physicals, describe the legal framework and identify confidentiality challenges related to reproductive health, describe the legal framework and identify confidentiality challenges related to behavioral health, and describe the legal framework and identify confidentiality challenges related to disciplinary referrals. Today's presenters are Abigail English and Laura Bray. Abigail English is a lawyer, researcher, and advocate for the rights of vulnerable young people. Since 1999, she has directed the Center for Adolescent Health and the Law. From 1976 to 1998, she was an attorney at the National Center for Youth Law in San Francisco, California. Her research and advocacy have focused on health insurance and public financing of care for adolescents and young adults, consent and confidentiality protections, and sexual and reproductive health care. Her work focuses on sexual exploitation and sex trafficking of adolescents and young adults. Laura Bray joined the School-Based Health Alliance staff in October of 2000. During her 13-year tenure, she has served the organization in a number of capacities, including Director of SBHC Training and Technical Assistance Center, Associate Director, Director of Programs and Professional Services, Senior Training and Technical Assistance Specialist, and, as of 2015, Vice President for Strategy and Knowledge Management. In her latest role, she oversees all the organization's training and technical assistance activities, development of technical assistance tools and resources, continuing education offerings, including monthly webinars and our annual convention, and executing professional services contracts and consultancies. Her 30-year career experience includes migrant health, public health, nonprofit administration, management, family planning, adolescent health, consultant services, training, coaching, technical assistance, and teaching at the secondary and college levels. School-based health care at the state and national levels has been the focus of her work for the last 20 years. She was the director of North Carolina's SBHC program, director of American Medical Association's guidelines for adolescent services in SBHCs, senior partner with Chicago Healthcare Management Consultants, director of Women's Ambulatory Care Programs for Fantas Health Center, Cook County Hospital, and director of Bilingual Health Education Programs for the Illinois Migrant Council. Laura has a Bachelor of Arts in Teaching, French, Spanish, and School Health Education, a Master of Science in Community Health Education and Administration from the University of Illinois in Urbana, and postgraduate studies in qualitative research at the University of Chicago. Without further delay, I will turn it over to today's presenters to begin the webinar.
Thank you very much, Erin. This is Abigail English, and I'm delighted to join everyone this afternoon to talk again about protecting confidentiality in school-based health settings. We're going to focus today on 4 case studies that we selected after the last webinar. What I'm going to do in today's time is very briefly review a few points from the confidentiality webinar that took place in December, just to highlight the content so that any of you who were not participating in that webinar. Can you see my screen, everyone? I think maybe you couldn't initially. Are you able to?
Thank you.
Okay, great. So the first thing I'm going to do is just very briefly review the webinar in December, highlighting the topics that were covered so that any of you who did not join that webinar can go back and look at the archives and get the detailed information, and then go straight into 4 case studies related to a well child visit and sports physical, a family planning visit, a behavioral health visit, and a referral as an alternative to discipline. So in December, the first thing we talked about was the rationale for confidentiality protection, which really is to avoid negative health outcomes by protecting the health of adolescents and protecting the public health. And the mechanism for doing that is to encourage adolescents to seek needed care by assuring them of confidentiality protection. And this is supported by decades of research findings that have documented that many adolescents have privacy concerns, that adolescents are primarily concerned about disclosure of information to their parents, and particularly concerned when that information is related to sexual behaviors and substance use and mental health concerns. Those privacy concerns that adolescents have influence whether they seek care at all, when they seek care, where they seek that care, and once they do seek care, how openly they talk with their health care provider. The legal framework, which we reviewed in considerable detail in the December webinar, is comprised of a complex patchwork of state and federal laws, all the way from the Constitution to statutes and regulations and court decisions. Many of the sort of most prevalent laws have pertained to reproductive health and rights, but important ones also concern the roles of families, the status of minor children, and the rights and responsibilities of parents. I think it's important to remind ourselves as we start out looking at the case studies today that consent and confidentiality are linked really closely. And in fact, I put it in quotations on the slide because people sometimes say consent and confidentiality as if it's sort of one phrase, one word. And they're not identical. But they are closely linked in clinical practice, in ethical guidelines, in professional policies, and in state and federal laws. And we'll sort of parse that a little bit and take it apart in talking about the case studies today. So let's turn right away to the first case study. A 13-year-old male comes to the health center for a routine well child or well adolescent visit and a sports physical. Really, the primary hook is for it to come for a sports physical. And we need to think about what clinical services will be provided, whether any consent issues are raised by this visit, and what are the confidentiality issues involved. So we have a poll question for you all to answer, and that is, when an adolescent comes into your health center for a well adolescent visit, do you discuss confidentiality at the beginning of the visit?
Attendees will now see a poll question on their screen. Please respond by clicking on the appropriate answer. We'll give you about 30 seconds. About 5 more seconds to respond. Thank you so much. I see that about 64% of attendees do address confidentiality with adolescents at the beginning of a well visit. 14% said sometimes, and 23% said not sure.
Great. Well, that's very helpful. And as with the other poll questions in this webinar, there isn't a correct answer. Often the answer will depend on specific information about the situation that isn't provided in this very skeletal case study, but it's important to have a sense of how often people do discuss confidentiality at the beginning of the visit. And we'll go on to think a little bit more in depth about this. Some of the kinds of clinical services that might be provided in this visit and might be guided by the protocols or screening tools that are listed here on the slide include a risk and strength assessment that one could identify from Bright Futures, the CRAFT alcohol and substance abuse screening, a depression screening, the patient health questionnaire number 9, a physical exam including reproductive growth and development, and a cardiac and musculoskeletal system assessment, which of course would be particularly important for the sports physical aspect of the visit.
Abigail, I'm sorry to interrupt. We are not seeing your slide, so I'm going to pass you the controls again quickly. You should see that notification pop up.
Okay. Yes, I did not see the notification earlier, right after the poll question, so I'm not sure why you weren't able to see them. Can you see them now?
And thank you so much, and again, I apologize for interrupting.
Oh, that's fine. Maybe we should do that after each of the poll questions, just in case that was the reason why they disappeared. But I'm going to go through them very quickly to get back to where we were. So I was just quickly reviewing the clinical services that would be provided in this well adolescent sports physical visit. The risk and strength assessment, the substance abuse and alcohol screening, the depression screening, the physical exam including reproductive growth and development, and the cardiac and musculoskeletal system assessment. So in terms of consent issues, it's quite possible, depending on exactly how your health center has structured its consent process, that the services provided as part of this sports physical and well visit would be encompassed within a consent, a general consent that the parent has already signed. So there may not be an issue about whether the minor himself could consent to any of these services, but just in case this were a situation where the parent had not signed a consent or where the consent didn't encompass what was needed, we can just review the fact that virtually every state, I think it's 46 or 48 states, do allow minors to consent for drug and or alcohol counseling or treatment, and that it's important to remember that there are, in addition, special federal drug and alcohol confidentiality rules, which I'll go into in a moment. And there are also, in those minor consent laws that allow minors to consent to drug or alcohol counseling and treatment, there are provisions that deal with informing parents. And so it's important to know in your state whether the drug or alcohol laws that allow minors to consent also say something about whether and when parents should be involved. With respect to the depression screening, not quite as many states, a little over 1/2 of states allow minors to consent for outpatient mental health counseling. And those laws vary quite a bit in terms of the very specific provisions that they include. They may vary a little bit in terms of age. They may vary in terms of whether a specific number of visits is allowed before the parents need to be involved, or before parents' consent needs to be obtained. And then there are also variations in the rules related to what kind of information or whether any information should be shared or could be shared with parents. So just for example, some states have provisions that say the healthcare professional should involve the parents unless they determine that it would be detrimental to the health of the minor to do so. So that's the type of variation that one might see in one of these laws. So I think this first case illustrates some of the themes that are often important in thinking about both consent, but particularly about confidentiality issues. And some of those themes have to do with whether we're talking about general care or whether we're talking about what are often referred to as sensitive, quote-unquote, sensitive services. So going back to one of the earlier slides, the issues around which minors tend to have, adolescents tend to have the greatest concern about disclosure have to do, not surprisingly, with substance use, mental health, and sexual activity. So there are potentially different levels of concern about confidentiality with regard to these sensitive services. There may also be differences in the laws around these different services. So for example, there may not be as strong a level of confidentiality protection from a legal perspective related to general care as there is related to, let's say, contraceptive services or drug and alcohol services. Another theme has to do with the contrast or the relationship between legal requirements and ethical obligations. There may be a number of situations in which a healthcare professional or you as a healthcare professional may have an ethical obligation to protect the confidentiality of the information about your patient or the patient's privacy. but the law may not be explicit around that. And so that's an important distinction to keep in mind. Just because there isn't a law doesn't mean there's no obligation to keep the information confidential. Another theme is that there are differences between absolute and conditional confidentiality assurances. Sometimes a healthcare professional will say, everything you tell me is confidential. That sounds like an absolute assurance of confidentiality, whereas in reality, confidentiality is never truly absolute, either really from a legal standpoint or from an ethical standpoint. There are always situations in which it is either legally or ethically either necessary or appropriate to break confidentiality, and we'll explore some of those in some of the other case studies. And then finally, under HIPAA and state confidentiality laws, the important question is, who is it who authorizes disclosures? And again, we'll explore that with some of the other case studies, but it's an important theme to raise here. And from a HIPAA perspective, what we need to remember is that the HIPAA privacy rule says that when a minor is authorized to consent to his or her own care and does consent, that minor has the status of an individual under the HIPAA privacy rule and has the same rights to control information that other individuals have, and one of those rights is to be the person who authorizes disclosure. And then, of course, as things are never as simple as they seem on the surface, there are the exceptions to that with respect to certain situations when parents may want access. And again, we'll explore that in one of the later case studies. So still talking about the first case study, in the screening interview related to use of substances, alcohol, and other drugs, on the screening interview form, there are two quotations that I thought it was important to put here on the slide. And the first says, at the beginning of the interview, I'm going to ask you a few questions that I ask all my patients. Please be honest. I will keep your answers confidential. And that's not qualified there in that screening interview form, but of course, as we'll look into in the course of today's discussion, confidentiality is never absolute. So the question arises as to when one informs the young person about the limitations of confidentiality. The second notice that's part of this screening interview form, craft screening interview form, is at the bottom of the form there is a confidentiality notice that says the information on this page may be protected by special federal confidentiality rules, and cites the rule, which prohibit disclosure of this information unless authorized by specific written consent. A general authorization for release of medical information is not sufficient for this purpose. And that raises, again, the question that I just mentioned a moment ago, which is, who is the person who should give the authorization? And ordinarily, a parent would be the person who would give the authorization for a child for medical information or records to be disclosed, but both under HIPAA and under these federal confidentiality rules, there may be circumstances under which, if the minor is the one who has consented to the care, to the drug or alcohol care, then the minor might be the one whose authorization was required. So turning to the depression screening questionnaire, one of the questions on that questionnaire is, how often in the last 2 weeks have you been bothered by any of the following problems? And the last of those that are listed is thoughts that you would be better off dead or of hurting yourself. So this falls right into a classic exception to the confidentiality obligation of a healthcare professional, and that is when a young person or a patient of any age really is expressing things that reveal that they are a danger to themselves or others, that may fall into a situation, an exception to confidentiality, certainly from an ethical point of view and potentially from a legal point of view, where it's necessary to notify someone. There has been case law in a few states. There was a case in California a long time ago where a young person was seeing a psychotherapist and was suicidal or expressed some suicidal thoughts and ultimately did commit suicide or attempt suicide, and there was a lawsuit, and the court said that the psychotherapist may not have had an obligation to disclose the information to the parents, but definitely had an obligation to take protective measures and disclose it in some fashion to be protective. And of course, another very famous case from California emerged where the patient at the college level was a danger to another individual, and in fact did shoot the other individual. It was his former fiancée, I believe, if I'm not mistaken. And out of that case came the duty to warn, where there's an identifiable victim, intended victim, that is revealed in a psychotherapy situation. So those are both situations that might be quite unusual to arise in a school-based health center setting, but it could occur, and so it's important to keep those in mind. So Laura, I'm wondering whether you have any comments from a clinical or a best practices perspective. Oh, I think I wanted to just make a comment about the pre-participation physical exam, the sports physical. And then it actually would be very helpful to get your comments about this, Laura. Okay. The AAP has a pre-participation physical exam questionnaire or form that contains a very detailed evaluation that's really quite similar to some of the Best Bright Futures questions. And then at the end of it is a much shorter one-page form that's a clearance form on which the physician's conclusions about whether the young person is cleared to play the sport. And if not, a reason must be given. So that raised in my mind the question, let's say the cardiac assessment showed irregularities. Who would be informed of that beyond the student, presumably? The parent, the coach, the school administrator? This is not an issue that falls in the sort of traditional quote-unquote sensitive services area, but are there any limitations on who would be informed about this? So I'll pause here, and Laura, if you have any comments about any of these screening issues and the confidentiality concerns associated with them, that would be great.
Okay, I have a couple. So I'll start with the slide you're on right now about, who is informed. Well, first of all, in this instance, the student came in for we did a well child visit, and they needed a sports physical as well. The student and the parent at that point would be informed as the results of that visit, because usually the parent is signing off on that sports physical request. But in my opinion, it doesn't have to be. If they're going to play sports, they have to turn it in. Therefore, the coach and probably the school administrator will be informed. But it doesn't have to be submitted if they've decided not to play because of what they found out. And in that instance, it could just be given back to the family and they can decide what they want to do with it. So in this instance, if they're going to play sports, you know, the parent is basically giving permission to share this with the coach. And of course, anytime anything goes like that, it's going to be a part of the school record. That's that first case. That's in terms of the sports physical piece for me. The one I want to go back to is about depression screening in general and drug and alcohol screening. So as of the most recent revision of the Bright Futures recommendation, which is our national standard for screening for children and adolescents at the well visits, as well as any prevention, you're supposed to be following those guidelines. They have included depression screening as a requirement. And it is now becoming a requirement within a lot of the CHIPRA measures. That means it will be required by managed care organizations. It'll be required by some Medicaid offices. And it will also be required by NCQA, the National Committee on Quality Assurance, if you're going for patient-centered medical home and things like that. However, the PHQ-9 is not necessarily the requirement. So the difference between this, there are two depression screening tools. One is the PHQ-2, which is just 2 screening questions. And that person who gets a positive score on those 2 questions would then be referred for further assessment, such as a PHQ-9, which actually gives you an initial, it guides you to a diagnosis that should then be either the mental health provider, in most instances, would be looking at that and work with their primary care provider if there's medication needed or something like that. But the PHQ-9 is the only 2 questions that are recommended and required by Bright Futures. So you can always go further, but you are going to be required to do depression screening on the preventive visits. And then in drugs and alcohol, this is an actual, the craft, if you're not using it now, actually does give you an initial diagnosis too, whether the patient or the student is alcohol dependent or drug dependent, and the need to refer and things like that. So if you're doing just screening and you're not actually doing a complete assessment, the screening questions that are in Bright Futures or in any of those screening tools would then lead you to go and get the craft. But many of our school-based health centers are going ahead and doing the craft rather than skipping another, having to have another element added into it. So those are my my comments on that. And Erin, I'm going to turn to you and see if we have any questions right now related to case study 1.
Thank you, Laura. We do not have any questions that have rolled in thus far. If attendees have any questions about this case study or these case studies that are coming up, please type them into the chat box and we will respond in between each case study.
Great. Thanks. Well, then let's move on to case study number 2. This is probably a very familiar scenario for you. A 16-year-old female comes to the health center for a family planning visit. And again, we need to think about what clinical services would be provided as part of that visit and whether there are any consent issues related to the family planning visit, and then what are the confidentiality issues associated with a family planning visit. And we have a second poll question here for you, which is when an adolescent has a positive pregnancy test, do you disclose the information to her parents? And your options are yes, no, sometimes, or not sure.
Thank you, Abigail. We've launched the poll question on your screen. Attendees will give you about 30 seconds to respond. Thank you. About 5 more seconds. Thank Thank you. I'm showing that 84% of attendees indicated no, they would not disclose this information to the parents. 8% said sometimes, and 8% said not sure.
Great. Well, that's very helpful. I'm going to move to the next slide, and then Erin, you can tell me whether you are able to see the slide or whether we need to have me show my screen again.
You can see the slide. We're all set.
Great. Terrific. Okay. So we have the 16-year-old female who's come in for a family planning visit. She had unprotected sex. She has a pregnancy test, and the pregnancy test, fortunately, is negative. But there would be other tests that you would either consider or actually order, and they would include an HIV test, a gonorrhea test, a test for herpes type 2, or a chlamydia test. And so those tests all might raise issues of either consent or confidentiality. Then because her pregnancy test was negative, it would be important to make sure that she's using contraception going forward. And so you would consider offering her a LARC, or a long-acting reversible contraceptive option. So with those services in mind, what are some of the consent issues? Well, first of all, minors can certainly consent to pregnancy testing. In fact, they could go to the drugstore and get a test that they could administer themselves, but there would be no barrier to their consenting to a pregnancy test in any state. And again, in every state there is some basis for minors to consent to screening and diagnosis, or diagnosis and treatment of sexually transmitted disease. So most of the tests that were listed previously as ones that would be considered or ordered for this young woman would be ones that she could consent to on her own, even if independently of that her parents had not signed a consent form that encompassed all of this. HIV testing is interesting in that HIV certainly is a sexually transmissible virus. If one dives into the weeds of state laws, one might have a concern in a small number of states of the technicality of whether minors can consent to HIV testing, because HIV might not be listed in state regulations as a sexually transmissible disease, even though it is. And there might not be an explicit provision saying minors can consent to HIV testing. However, I would argue, and I think it's defensible, that minors can consent to HIV tests anywhere. The other issues relate to the LARC and contraception. And again, this is an interesting issue when one dives into the weeds, and that is that only in about 2/3 of the states does a state statute exist that clearly says minors can consent to contraception or prevention of pregnancy. However, there are very strong, I believe, very strong arguments that minors should be able to consent in any state based on the constitutional right of privacy and a long history of Supreme Court decisions about minors' privacy rights to choose whether or not to use contraception, dating all the way back to the 1970s. However, there are some There are some risk managers in various healthcare settings that are not comfortable with that unless there's an explicit state law. And there are some communities in which the community has decided that the student health center, the school-based health center, may not, at least may not dispense and sometimes may not prescribe contraception. And in those situations, it is, of course, true that in a Title X funded setting, in every state, minors can consent to contraception for themselves. But turning to the confidentiality issues, let's say, for purposes of discussion, that the test results were positive. So let's say there was a positive pregnancy test. Well, obviously the issue arises as to whether the girl is going to continue the pregnancy or whether she's going to seek an abortion. And although obviously that is not a service that is provided at the school-based health center, it is important to be considering what the implications of that are from a confidentiality perspective. So if she decides that she's going to continue her pregnancy, at some point, either her parents or at least some other adults need to be made aware and need to know. And so there are issues around how and when to involve the parents or other adults. If she decides to seek an abortion, the vast majority, upwards of 40 states now, do have laws requiring either parental consent or notification, but they also have laws allowing a minor to seek authorization from a court, usually referred to as a judicial bypass, that would enable them to receive an abortion without parental consent or notification. And states vary widely in terms of what the procedures are for that and whether there are lawyer panels available to advise young people and what organizations can be helpful in that regard. If the sexually transmitted disease tests, any or all of them, were positive, no state, to my knowledge, has a law requiring that that information be disclosed to parents. And most states, if they address it, say that the information should be confidential. Although if the state law does not address it, then under HIPAA, there would be discretion with the healthcare provider whether or not to disclose or make the information available to parents. And finally, with respect to the HIV test, there are some variations in terms of state laws that allow or require healthcare professionals to disclose information to parents, although the number of those laws is very small. And again, if law is silent, then the healthcare professional under HIPAA would have discretion exercising medical judgment, but many states have stringent laws related to the disclosure of HIV testing, not allowing that to be disclosed without the permission of the patient. So ordinarily the default would be that the patient's permission would be required, and then there would be obviously a need for some extensive discussion with a young person who had tested positive for HIV as to how they would proceed in terms of either involving their parents or not and receiving treatment, and where they would do that and how they would do that. So before we move on to the next case study, I'm wondering, Laura, if you have comments again about this one with respect to either clinical considerations or best practices. I'm sure this is a scenario that arises quite frequently, the family planning visit.
Oh, yes, it does. And I do have a couple of comments. First, starting out with the situation of just minor consent in a school-based health center for family planning. It's quite uncommon to, or let's I say, it's not common to have to allow family planning distribution of birth control methods in a school-based health center. And actually, even though federal law would allow it, and there's no state law that would supersede the federal law in terms of restrictions of requiring parental consent or something like that for contraception, some school districts have actually created policy that the school-based health centers must follow in order to be there. So they have created policy where it's not allowed to be, they're not allowed to provide family planning, dispensing, or anything like that. Depends upon what the policy says. And in some districts, there's really not a policy. It's sort of this desire to not go there. And so the encouragement that, or not encouragement, but the feeling we have, unless in our organization, is usually if it's not prohibited by state statute or by the school district statute, that if you're if you're starting a school-based health center with a population where you know you might have to address this, it's better to address it in the beginning and try to deal with that controversy from day one. Also including the parents. Sometimes you will have a lobby from parents where they are in support of this as you're doing that needs assessment. That's why the planning process is so important. And then in addition to that, you may actually be able to have some of the young people speak out about this, or even school nurses or physicians from the community. So it's not something that just ignore it, as maybe people had done in the past, but if you think it's going to be an issue, then, and it probably will, and there's nothing prohibiting you right now from doing it, it's a good idea to at least try to address that and see if there can be some type of policy regarding it, whereas at least you might be able to provide the actual prescription, and maybe they can get it filled somewhere else, or however it would be dealt with. So that's just kind of our recommendation from experience. The second part of that is don't think that if there is a district policy that you can't get it changed, or there's a building level policy that a principal had. There are cases where new principals came into a district where it might have been prohibited or it might never have been allowed, and the actual principal was the motivating factor when he realized what the pregnancy rate was in his school and what was going on, and he actually, in the one instance of recent that I know of, he actually lobbied and got the school-based health center and the whole advisory group of the school-based health center in his school district to get going, and actually they were able to overturn that, and now they do provide family planning in that school-based health center. So there are a number of cases where that has changed over the last few years. The other part is, having worked in Title X programs, I do think still after all this time there is misunderstanding between what can and can't be done. And most providers still feel that, you know, if you're not in a Title X setting, of course they seem to really want parental consent. But the only time, just so you know, the only time that federal law in a Title X program can be superseded, and you know, where you actually can require a stronger consent, is in the case where the state law, there's a state law that supersedes the federal, and then you have to follow the state law. And I'm going to go back to you as a lawyer, Abigail, but I'm pretty sure at least that's the way it was when I was in Title X programs. So unless there was a state law that said we had to do a higher consent process or, you know, follow a higher rule, we would follow the federal law.
This is very confusing to people, and I'm really glad you raised it, Laura. The situation is that in a Title X funded setting, parental consent cannot be required. Period, the end. The reason it has become as confusing as it is that outside of the Title X setting, there are providers and risk managers and advising lawyers and school districts who believe that unless there's a state law that explicitly says, yes, minors may consent, and you don't need parental consent, that you do need parental consent. And that, in fact, is not true. Outside of the Title X setting, unless there is a state law that says you need parental consent, you don't need it because there are constitutional bases and other bases for giving minors the ability to consent for their own contraception. And the final kind of wrinkle on this is something that arose in both Utah many years ago and Texas much more recently, and that is where states tried to limit minors being able to consent even in a Title X setting. And in both of those instances, court decisions determined that you cannot require parental consent in a Title X setting or under Medicaid. However, states can impose parental consent requirements on state-funded family planning services. So that's what happened in Texas. They tried to impose parental consent for contraception and STD services in all publicly funded settings, and they couldn't do it for the federally funded ones, so they only do it in the state-funded ones.
Okay, so to put another layer on that, because, and this is important for school-based health centers, because Title X, any money that is given and included in the Title X program is considered Title X program funds. Correct, Abigail? That's how it was?
Yeah. Yes.
So if state money augments a Title X program, or Medicaid money is augmented, and it's all blended together, it's now considered Title X, and it's subject to Title X rules.
That is correct.
And so,
I believe that is correct.
At least that's how, I mean, I haven't worked in Title X in a number of years, but at that time, that's how it was. So yes. The reason I say that is because those sites that do some family planning, many of them that are school-based health centers that do family planning, they are using Title X money. They've managed to get it into their program in one way or another, or they're sponsored by a health department or a medical sponsor that has a Title X program that has put some of that funding into that program. Or they're bringing in a provider just to do family planning that is funded by Title X.
Right.
So be really careful, because what Abigail's telling you is if it's Title X, it's Title X, it has to follow the federal rules.
Right. Thank you, Laura. That's really important that we clarified that. I hope we clarified it and didn't just confuse people. But
I hope not, but I think it's really important to realize
it's very important.
That those numbers, like federal Title X means a lot. It's a categorical grant, and it's a federal rule. So you have to really be careful, where you're getting your money from and what rules then you impose with that money, because you too could be brought up, if you're not following correctly, you could be brought up in a court case. So anyway, that's enough said about that, unless there's any other questions now in the queue, Erin.
We do have two questions about this case study. The first is, in terms of positive HIV tests, are either of you aware of any requirements to report that to local health jurisdictions for testing or for tracking purposes?
There are requirements to report data about positive HIV tests, and I honestly can't remember now whether it's to the local health department or ultimately it's to the CDC, but that's done anonymously. That's not done with anybody's name, as far as aware.
And it is to the local health authority unless you don't have one. And it's been that way for years, but it's never got a name attached to it. And it's also for any sexually transmitted diseases that you've tested for.
Correct.
They expect you to report that. It's for public health data only.
That's correct.
Thank you. The second question we have is, how does parental consent apply to FQHCs who require parental consent for general services? Many of the FQHCs will require parental consent to become a patient, even though they may state no parent consent is required for reproductive health services.
Well, I'll give a general answer. I haven't delved into the finer details of the FQHC regulations, but I would say that this would be similar to a situation where the school-based health center requires parental consent to use the services of the health center, but may make an exception for minor consent services. In other words, for sexual health services or other services that the minors are allowed to receive on a confidential basis based on their own consent. So I would think that would be a starting point for thinking about how the FQHC situation would be treated. But I would have to delve more deeply into the finer points of the FQHC regulations to be certain. Laura, do you have any comments about that one?
A little bit. So I'm not sure, when you ask the question, are you talking about going to the actual main FQHC site, or are you talking about the fact that the school-based health center is the site and the FQHC is the sponsor? That said, if there's a consent on file at either location and the student is now requesting confidential services, there's no addition, unless there's some state law which, that could supersede this, there's no requirement then to get another consent to do family planning, to do a confidential service or anything like that. The issue comes in as to whether they can pursue the service without a parental consent. And at an FQHC, I mean, it really depends on your policy, but in many places, an FQHC there should be no issue as to why they can't provide confidential services if it's not against the laws in their state. For those services that they would have to require the parent's consent. It shouldn't be an issue. However, I can't say what your own FQHCs have decided. In most school-based settings, even though they may not require the parental consent, most of them require parental consent to use the school-based health center. And therefore, any of the services that they want to access, they can access once that's done. However, in certain states, like California and Oregon and others, they do sometimes make exceptions for that, and they let the minor consent on their own for those confidential services. But it really is not the majority of the school-based health centers. And I don't know if that answers the question, but I hope it does.
I think we've at least provided some threshold information to go on here. So, excuse me, turning to, can you still see my screen, everybody?
We can.
Good. Turning to case study 3, a 15-year-old female who is experiencing anxiety is receiving behavioral health services at the health center. So again, are there any consent issues here? What are the confidentiality protections that would apply in this situation? And what disclosures would either be permitted or required? And we have another poll question here, which is, would you discuss the girl's care with her mother if her mother called and asked questions? And again, your options are yes, no, sometimes, or not sure.
Thank you, Abigail. We've launched the third poll, and we'll give you about 30 seconds to respond. And about 5 more seconds. Great, thank you. I'm showing that 9% said yes, they would discuss the girl's care with her mother. 39% said no, they would not discuss the care. 39% said sometimes, and 13% said not sure.
Thank you. That's very helpful. I think that the sort of variations in the responses to these 3 poll questions illustrate that the different situations are really quite different and call for different responses. So I think that's very useful. I'm going to move to my next slide, and Erin, you can tell me if it's visible.
Yes, it is.
Great.
Thanks, Abigail.
So the services that this girl is receiving in terms of counseling for her anxiety are likely within the scope of the general consent for health center services, assuming that her parents signed a general consent. And again, just reviewing what we talked about in the first case study, in about half of states, minors are allowed to consent for outpatient mental health counseling, sometimes with an age limitation of 15 or 14, sometimes without an age limitation, sometimes with a limit on the number of visits, sometimes with specific other provisos related to the involvement of parents or limitations on that consent. So thinking first about what are the confidentiality protections that would apply in this situation. First of all, just to highlight whether it would be applicable here or not, the HIPAA privacy rule does contain an elevated level of protection for psychotherapy notes. And psychotherapy notes are notes that are kept by the psychotherapist that are private notes. They are not made part of any other file, so they don't become part of the electronic medical record. They don't become part of, any other sort of system-wide files. They can't be then subpoenaed. They are protected at a higher level under the HIPAA privacy rule, just so that people are aware that that exists. And again, I'm not delving into the details of that right now, but it is important alert. Again, under the HIPAA privacy rule, the minor is treated as the individual if she is authorized to consent and does consent. So that's a little bit ambiguous if you have a situation where the parent has already given consent for her to receive services at the school-based health center, but you're in a state where she could consent on her own to outpatient mental health counseling, and she is consenting. So in that situation, I would take the more protective view and say if she's consenting, then she would be considered an individual under the HIPAA privacy rule, and whether her parent would have access to information about her care would depend on state or other applicable law. So in this instance, let's say the minor consent law in your state, which said minors can consent to outpatient mental health counseling, also said that the healthcare professional can share the information or must share the information unless it would be harmful to the health of the minor to do so. That would control in this situation. Then it's also important, in addition to the HIPAA privacy rule, to think about what kinds of protections are included in state law confidentiality requirements. And clearly in, I think, every state or almost every state, there's a psychotherapist patient privilege. And it's important to remember these privileges really are only technically applicable where your information is subpoenaed or you're asked to testify in a court. So if a mother calls up and says, I want the information, what kind of care are you providing to my daughter? You don't cite the psychotherapist patient privilege, although people do, and it's not uncommon for that to be used in a more general kind of way to refer to the confidentiality obligation. But I think more appropriately one refers to the ethical obligation that a counselor or any kind of mental health professional has to maintain the confidentiality of their patients' information, as well as specific legal requirements that may be contained in state laws. And there are multiple state laws that address the confidentiality of information about mental health services. Those laws also sometimes include an exception to patients' access to their own records that gives the provider discretion to withhold access to the records if they think it would be harmful to the patient to see the information. And that might extend to withholding access to the information if they thought it might be harmful to share it with the parent, if the parent was sort of the authorized representative of the patient. So those are the kinds of protections that apply. And then there are, of course, exceptions to those protections. One of the leading ones is the requirement of reporting of known or suspected child abuse. And it is possible that it might emerge in the course of the counseling with this young girl, that she was subject to some form of abuse or neglect, including possibly sexual abuse or neglect at her home, or sexual assault by other individuals, and then it would be necessary to evaluate whether those suspicions or that information fell within the framework of the state's child abuse reporting law, which of course exists in every state. It also might emerge in the course of the counseling that she was a danger to herself, potentially to others, but perhaps more likely a danger to herself, as we mentioned in the first case, and that would trigger an obligation to take some kind of protective measures or to notify either the parents or the authorities. But then going beyond those situations in which there is a legal obligation to disclose otherwise confidential information, there are situations where the disclosure may not be required, but it may be discretionary. And it may be discretionary either because it's explicitly permitted by the law, sometimes in the minor consent law itself, sometimes in other state laws, or because the law is silent about disclosure to parents, and in those instances, the HIPAA privacy rule says if laws are silent then the healthcare professional has the discretion to disclose the information to a parent. So that all has a bearing on whether one would decide to discuss the information with the girl's mother if she called and said, I want to know what's going on with my daughter's care. So it might be legally permissible to do that. It might be legally required either to discuss it with the mother or to take some other steps. And I'll pause there in case Laura has some comments about this, because again, I would think that this might be a case that would arise perhaps not quite as commonly as the family planning visit, but not uncommonly in a school-based health center setting. Laura?
Laura, I believe you're muted. We are unable to hear you.
I'm sorry, I'm back. I was muted. Okay. So yes, I do have some comments. I think a case like this does come up a lot, more than we think, maybe more than we realize. However, it depends on a number of things. So first of all, the general consent for care. Having worked with sites over the years, I found that if they spell out at the beginning mental health or behavioral health services as one of the services they're consenting for, then they feel that the center feels they have the consent they need. If it just says it's consenting to use, that it consents to all the services and it spells them out, if it just says consent to use a school-based health center, I think that in that sense, I've noticed the mental health providers in particular being concerned about getting another consent for mental health treatment once they've gone past the number of visits allowed by the minor consent law. So if it's 6 visits and they still feel, and most of the time they don't need to see them after that in many instances, but if they think it's going to be longer than that, they consider that more of a longer-term therapeutics condition, and they would want to get another consent, especially also getting the child to consent to this. And at that point, they would talk to the patient. We've seen 6 times. Really think it's time, Bobby, maybe we need to bring your parents in on this so they know that you've got an issue. Maybe they need medication. That's another area. If they're going to need med management with this, that has to be managed by a psychiatrist. At that point, they may even feel more so that they need to talk with the parent, and that would be something where the primary care and the mental health provider would consult with each other. So I think there's it's a gray area, but there is some variance in that. But if a school-based health center really has a policy that says, for the minors, we'll see you for 6 visits without getting an additional consent, but after that we do, then they should explain that at the beginning, just like they explain their confidentiality policy, that this is what would happen. So, like if you wait till the 6th visit and go, oops, now I got to get your parents or your guardian's consent, that could be an unexpected surprise.
I think that raises a really important ethical point, Laura, which is that in many of these instances, there may be a legal framework or a school-based health center policy or a school district policy or a sponsoring agency policy. But often it is more appropriate and desirable not to just act based on the policy, but to engage the young person and say, for a variety of reasons, we need to involve your parents. How can we do that? Or as Laura said, at the outset of treatment, I'm happy to see you for a number of visits, but at some point, if you need more care, we may need to involve your parents, and I want you to understand that from the outset. And that's really an ethical obligation as much as a legal one.
Erin, do you have any other questions on this one that have come in?
We do have several questions. We'll try and get to a few of them now. And if we don't respond to your question on this webinar, we will be in touch with you after the webinar via email. So the first question that I have is a question from New York City, that the Department of Education is requiring school-based health centers to tell the principal that an abuse or neglect report has been made and then give the state ID number to the school. Is that a breach of confidentiality?
I would not know the answer to that without looking at New York regulations. I'm sorry. I wish I could answer it, but I don't feel comfortable without really looking at New York regulations.
We do have a second question. An attendee writes that they are in the process of having minors use their patient portal for confidentiality results. Are you aware of how other school-based health centers handle patient portal access to parents of minors?
Laura, do you have a comment about that?
That's a very good one. This, in the school-based setting, and if there are adolescents in that, I've not known of the parent being actually given their portal for that student. For a younger child, of course. Very good question, though. I do not know. We don't have a lot of experience in that. So I honestly can't say beyond that. In the ones I know of where it's an adolescent, they've given them access, or if they've gone to a specialist, they've given the access only to the, related to an issue that would be a minor doctrine piece about confidentiality. They've only given access to that adolescent. But I think their question raises other issues now that we have EHRs about how they separate out confidential from non-confidential. We used to be able to do it in charts very easily. When the parent would request information, you could leave the part that was the confidential chart out of that. But how do you do that now?
Apart from the school-based health center setting, this is an issue that is under intense scrutiny and extensive sort of development out there in the world, both with respect to patient portals and how adolescent access and parent access is handled, and with respect to EHRs. And I mean, that could sometime be a topic for a whole separate webinar, which we might want to consider. But I think that it is evolving and is being handled, certainly apart from the school-based health center setting, in different ways at different sites and different institutions. So I'll stop there with respect to that, but it is a very important question.
So in other words, we can't give you a definitive answer, but great question. And I'm definitely going to keep that. This is Laura. I'm going to keep that in our queue for as we talk with more organizations around their EHRs and the use of portals, what they're doing and how they're doing it in terms of access. And then if there's any federal rules that come down, we'll start watching for that. And like Abigail said, maybe that will be another webinar in the next year or so. Any other questions, Erin?
I think we have several very specific questions that are coming in, so I will say to anyone that we have not posed your question, we'll take this information back after the webinar, do a bit more research, and be in touch with you in the next week.
Okay, that sounds good, and I will then move on to the last case study, which is a 16-year-old male is caught drinking alcohol on school premises and is referred to the health center by a school administrator as an alternative to formal disciplinary procedures. Again, are there consent issues? What kinds of confidentiality protections would apply, and what disclosures would be permitted or required? So on this one, I would say that the issue with respect to consent is not so much whether there's consent for the student to receive services at the school-based health center as the consent to the referral as a disciplinary alternative, and whether there are any limitations that are imposed on that by the disciplinary officers or the school itself, whether that has any effect on the type of care or the status of the care received. And Laura and I discussed this a little bit in advance of the webinar, and I know she has some comments on how this would sort of proceed, but presumably if the student shows up at the school-based health center, he has consented to the referral, and that the school-based health center and the school have to have some understanding between them as to what the implications of that are. And we'll assume that generally whatever services he would receive at the school-based health center would be encompassed by the consent that his parent had signed in advance. But even if they weren't, all states essentially have a provision allowing minors to consent for drug and alcohol counseling or treatment. So again, turning to the confidentiality protections, we've got the HIPAA privacy rule, but in addition, which I've discussed at some length, and there are detailed slides about it from the previous webinar, but also there are the federal drug and alcohol confidentiality regulations that were cited on that CRAFT screening form at the beginning of this webinar. And those regulations are very detailed and very strict with respect to requiring specific authorization for release of any information associated with drug and alcohol treatment. And again, if the minor is consenting to that treatment, then the minor's permission would be needed to disclose the information. There also might well be confidentiality requirements in the state's minor consent laws around drug and alcohol treatment, somewhat similar to, although not necessarily identical to, whatever was in the patient mental health counseling laws. So being familiar with all three of these sources of a confidentiality protection, the HIPAA privacy rule, the federal drug and alcohol regulations, and the state minor consent laws would be important. I put FERPA here with a question mark just because so often anything that's going on in a school, somebody said, well, doesn't FERPA apply? And the answer would be that unless something has become part of the school health record, then FERPA does not apply to it, and the applicable rules would be HIPAA and the other federal and the other medical confidentiality rules. So Laura, I don't know if you have any comments. Oh, I did want to say something about disclosures as really a segue to your comments, which is that it's quite possible that the school would request information, want to know how's he doing, is he complying with your treatment, plan, and so on and so forth. It's also possible that the parent would request information. It's possible that it might be necessary to consider disclosure to other third parties, particularly if there were information emerging from the care that revealed that the student was driving intoxicated, or was driving with others who were intoxicated, riding in cars with others who were driving intoxicated. So those would be considerations as well. And again, I'll let Laura comment, but I would say that beyond confirming to the school that the student was participating, had come to the clinic and was participating in the plan, details would not be forthcoming to the school and would only be forthcoming to the parent if that were consistent with state law requirements around drug and alcohol care. Laura?
Yeah, this is a complicated one. So that said, I think because when the school is agreeing to use the school-based health center as an alternative to discipline, you have to work out what that policy is between the school-based health center and the school itself in terms of how you will handle those cases. Because this is, instead of them being given maybe suspension or something like that, they are getting this as an alternative. And if they accept it, you know, the school is going to probably require something such as that their parents be notified. It could happen. And you have to see as a school-based health center if you're willing to have that in your policy and procedure. Second of all, that they want to know that they kept the appointment and that they're under care. But other than that, they'll want to know a lot more, like what Abigail said. And really, in your policy and procedure, you shouldn't be willing to give them a lot more other than to know they're under their care. They're under your care. You should see improvement. If they're requiring a lot more, they're saying, oh, we want drug testing, things like that, I really would caution you to put yourself in a position where you may not want to get involved. That's almost punitive. This is really giving the student an opportunity to go through, not for just drug and alcohol, but to really go through the screening process and see what's going on with them. It could have been, if you take alcohol away, it could have been they were caught smoking. And in the past, they would have been given a detention, or maybe they would be suspended for so many days. But maybe they're really suffering from depression or other issues going on. And so this gives them an opportunity to go to the health center, get a full assessment, at least with a mental health professional. Hopefully they'll get a well child visit or something like that to find out what's really going on with them, unless they're already under the care of the health center. And then, you know, they're going to help them with that as well, follow up. So again, I think it's looking at what is that policy and procedure you're going to create between your school-based health center and the school itself, and how it would operationalize. If the school, as a contingent to letting them come to you, especially in the case of alcohol or substance, they may require the parents be notified, and that would be their part, that they're requiring it be done because they're the ones who found them. So again, I would encourage them maybe not to do that, but maybe they feel they have to. So those are things that I think have to be worked out at a building level or at a district level about how they handle it. I do think the good news is that zero tolerance has been loosened by the Department of Education at the federal level, and many school districts or individual schools are realizing that basically when they do zero tolerance, they're actually getting the kids that need help out of the school system and into more trouble. And this is really giving them a venue to help them to stay in school and to get into some type of screening and maybe get into early intervention for problems they're having. So I think that's probably about all I can say about it. You know,
that's very helpful, Laura. And I think that this really illustrates very nicely that these issues around confidentiality in the school-based health center setting are a complex interaction of legal requirements, ethical requirements, clinical best practice standards, and negotiation with the school and the school district. And that all of those, and often the sponsoring agency as well, so all of those elements have to be brought together and I really appreciate your comments. I also appreciate the questions, and I know that we don't necessarily have time for more questions now, but I also know that Erin is planning to be sure that we get back to anybody who's posed a question. Some of them were very specific, and we wouldn't be able to answer them in this general setting. But I will just close here by saying that the case studies really illustrate a diverse set of issues around age, gender, family situation, clinical services with implications for consent, for confidentiality protections, and for required and permitted disclosures. The remaining slides, which you would see if you had already downloaded the PowerPoint presentation, are really from the prior webinar back in December, and talk about the importance of confidential care versus no care, the challenges that exist in protecting confidentiality in school-based health centers, the numerous strategies that exist for doing so, and that school-based health centers really play a very important role in providing confidential care and access to confidential care for adolescents. So thank you very much.
Thank you, Abigail, and thank you, Laura. And if anyone is interested in part 1 of this webinar series, it is available on our website as an archived audio recording. And we have recorded this webinar, and it will also be available on our website in the next 2 to 3 business days. So at this point, I'll ask if there are any final general questions. And while you're thinking of those last questions, I'll remind you that we have a 20th anniversary this year. School-Based Health Alliance is celebrating 20 years. And our convention is coming up this June 16th through 19th in Austin, Texas. And our theme is 20 years of collective impact for student success. Registration is now open, and we hope to see you all there. Additionally, School-Based Health Alliance is a membership organization. We rely on member support to be the national voice of school-based health centers. If you're not a member, we encourage you to join. We have 2 membership options, individual and organizational. If you have any questions about membership, you can contact us or visit our website at www.sbhforall.org/membership. So at this point, I'll look to see if we have any general questions that have rolled in. Great, thank you. It appears that we do not have any more questions. If we did not get to your specific question on this webinar, as Abigail said, we will be in contact with you via email over the next week. This presentation has been recorded and will be archived on the School-Based Health Alliance website in the next 2 to 3 business days. If you have any additional questions, please do not hesitate to contact us at programs@sbhforall.org. We're going to ask that you take a moment to fill out 3 poll questions that will appear on your screen. It's important for us to know how we're doing so that we can continue to meet your needs. Additionally, we will also be sending out a brief emailed evaluation survey within the next 2 to 3 business days. Please let us know how we're doing and any additional topics you would like us to cover. Our first poll question is, did this presentation meet your needs? We'll give you about 5 more seconds. The next question is, did this presentation provide you with usable ideas or techniques? And about 5 more seconds. And our last question is, would you recommend this webinar to others? Five seconds. Great, thank you. Thank you to everyone for attending this webinar this afternoon. And additionally, thank you so much to Laura and Abigail. Your knowledge on a very complex topic is so, so valuable. We hope you have a great afternoon. Thank you.